I'm Susan McCrossan and I'm one of the plastic surgery registrars from Yorkshire in the United Kingdom. In this video, we're going to discuss the diagnosis, management and controversies associated with the acute injury of the ulnar collateral ligament of the thumb metacarpophalangeal joint.
The most common type of ulnar collateral ligament injury is an acute injury, whereby the patient gives a history of falling on an outstretched hand with hyperabduction of the thumb at the metacarpophalangeal joint, and therefore causing injury to the ulnar collateral ligament, the UCL. This is often called a skier's thumb, as in countries where skiing is popular, this injury can be due to skiers falling while still gripping onto their ski poles. The ski pole acts as a pivot around which the thumb MCPJ can hyperabduct, resulting in an acute injury to the UCL of the thumb metacarpophalangeal joint. Of course, in the United Kingdom, there is not as many opportunities to go skiing, and therefore most common acute presentations of the UCL injury are due to a fall on an outstretched hand, usually at home, places of leisure, or on the street, and not somewhere as exotic as a ski slope. Less commonly, patients may present with a chronic injury to the thumb MCPJ, secondary to repeated abduction stress of this joint. This is called a gamekeeper's thumb, as historically a gamekeeper would need to wring the neck of pheasants or rabbits which had been shot during a hunt to ensure that the animal was dead. This recurrent twisting mechanism would cause a repeated hyperabduction stress to the MCPJ of the thumbs of the gamekeepers, resulting in chronic stretching of the UCL over time, and result in an instability of the thumb at the MCPJ. For the rest of the video, we will be concentrating on the acute injuries to the UCL of the thumb MCPJ. Now you may be thinking, why is it we get so concerned about the ulnar collateral ligament on the metacarpophalangeal joint of the thumb, given that there are two collateral ligaments, radial and ulnar, associated with each joint of each digit of the hands? Well, not unusual in surgery, the answer lies in the anatomy. The most common way of first visualising a joint is by plain X-ray. When one looks at the X-ray of a joint, whether that be of a finger or a thumb, they look pretty similar in structure. There's a bone at the distal part of the joint, there's a bone proximally, and a gap between the bones, the joint. Of course, this does not look at all like a stable construct, so let's look at a schematic diagram of a joint to demonstrate the parts of the joint responsible for stability and which are not obvious on X-rays. On either side of the joint, there is a collateral ligament attached to the bones, the radial and ulnar collateral ligaments. These collateral ligaments confer lateral stability to the joints. Looking at this lateral view of a joint, one can see that each collateral ligament is a fan-shaped structure consisting of two separate distinct components. There is the proper ulnar collateral ligament, which goes from the neck of the proximal bone of the joint to the base of the distal bone of the joint. That is to say, the proper collateral ligament originates from bone and inserts into bone. Then, there is the accessory collateral ligament, which also originates from the neck of the proximal bone, but inserts onto the fibrocartilaginous structure on the volar aspect of the joint called the volar plate. The volar plate spans the volar aspect of the joint and is attached to both bones, thus preventing hyperextension of the joint. As hyperflexion of joints of digits is not possible, there is no need for a similar structure on the dorsum of the joints. So, with the two collateral ligaments attached to both bones and to the volar plate, the three structures form three sides of a box, conferring significant stability to the digital joints. As a result of an injury stressing the joints, the collateral ligament can become detached distally. It can become detached proximally, it can detach mid-substance, or there can be an associated avulsion fracture, when the bone breaks rather than the ligament avulsing off the bone. These sorts of injuries can happen with any collateral ligament of any digit, and most of these are treated non-operatively. So what is so special about the ulnar collateral ligament of the MCPJ of the thumb? The issue is that, because of its specific anatomy, the ulnar collateral ligament of the MCPJ of the thumb can get what is known as the Stenner lesion. This was described by Bertil Stenner in 1962. When one looks at the anatomy of the thumb MCPJ, one can see that close by is a adductor pollicis shown by this arrow. This muscle attaches onto the extensor hood of the thumb by an aponeurosis on the ulnar side of the MCPJ of the thumb. The intact ulnar collateral ligament is positioned deep to the adductor aponeurosis. However, the adductor aponeurosis has a free edge proximally, and as such, if there is an acute hyperabduction injury to the MCPJ and the ulnar collateral ligament ruptures distally, the UCL can, because of the free edge of the adductor aponeurosis, flick out from its natural position deep to the adductor aponeurosis and come to lie superficial to the adductor aponeurosis as demonstrated in the diagrams. When this happens, the UCL is unable to reattach to the base of the proximal phalanx, where it should normally be, as the adductor aponeurosis is interposed between the avulsed end of the UCL and the base of the proximal phalanx. So the UCL cannot heal, and this leads to persistent joint instability. The chronic instability manifests as pain at the MCPJ whenever the patient tries to hold anything between the thumb and any of the digits, as in a pincer grip or tripod grips, and this can therefore cause functional problems with the patient's grip. This is an intraoperative photograph of a patient who is clinically suspected to have a complete rupture of the ulnar collateral ligament. This is the ulnar aspect of the MCPJ of the thumb, showing the adductor muscle, with its aponeurosis attached to the thumb extensor hood. The dots outline the free edge of the adductor aponeurosis, and one can see the ruptured ulnar collateral ligament sitting just proximal to the free edge, and it's superficial to the adductor aponeurosis. This is the Stener lesion. To accurately diagnose a UCL injury to the thumb MCPJ, it is important to have a high index of suspicion. As with all injuries, the mechanism of injury is important. Usually the patient gives a history of fall and outstretched hand. The patients complain of pain, swelling, and one may be able to see bruising or ecchymosis on the ulnar side of the thumb MCPJ, as is pointed out by the arrow. There may also be some radial deviation of the thumb at the MCPJ. The definitive test is to determine lateral stability at the MCPJ upon applying radial stress to the thumb at the joint. The key is to ascertain whether or not there is an endpoint when the thumb is subjected to radial stress, that is to say, abduction. If there is an endpoint, meaning one cannot completely open up the joint, it means that the rupture of the ulnar collateral ligament is incomplete, what is known as a sprain. If there is no endpoint, where one can feel the joint opening up fully without an obvious end to this, then one can assume the ulnar collateral ligament is completely ruptured. The importance of examining for an endpoint is that if there is no endpoint, that is to say the UCL has completely ruptured, it is then possible that the rupture has taken place distally and the ulnar collateral ligament has flicked out from deep to the adductor aponeurosis and now lies superficial to the adductor aponeurosis and is therefore a Stener lesion. Prior to examining the injured thumb, it is important to establish the baseline laxity for the patient, and this is important because there is variability in the degree of laxity between patients. To do this, one must first start by radial stressing the uninjured thumb's MCPJ, of course after establishing that this thumb itself has not had a previous UCL injury. The metacarpal of the uninjured thumb is first stabilised by the examiner, as shown in the photo, and then the thumb itself is stressed radially, as in the direction by the red arrow, to determine the baseline laxity of the uninjured thumb MCPJ. Then, the injured thumb is examined similarly. It's imperative to ensure that one does not inflict pain on the patient when radially stressing the thumb. Infiltrating the site of injury with local anaesthetic ensures a pain-free examination of the thumb. One must point out, for the sake of teaching perfect technique, that unlike what is shown in this picture, the examiner's hand, which is stressing the thumb, should hold the patient's thumb not at the distal phalanx, but at the proximal phalanx. This is so that the stressing force is directed only at the MCPJ of the patient, and not at both the interphalangeal joint and the MCPJ. One can clearly see the difference between the uninjured right and injured left thumb. The left thumb opens up almost completely on radial stressing. The dotted lines are parallel to the proximal phalanx and metacarpal in both thumbs. One can see the difference in the angle that one can get on stressing the injured left thumb compared to the uninjured right thumb. It's important to remember to perform the radial stressing with both the thumb fully extended at the MCPJ and partially flexed at the MCPJ. This is because the accessory collateral ligament is on full stretch when the thumb is extended at the MCPJ. So if the thumb is only examined in extension and the accessory ligament is intact, then one might miss the proper ulnar collateral ligament injury, as the presence of an intact accessory ulnar collateral ligament will confer some degree of stability. If the radial stressing is done under radiological control, one can see how the thumb opens out at the ulnar side of the metacarpophalangeal joint. This can be compared with the uninjured thumb's MCPJ. One can clearly see the differential opening up of the joint on the left injured side. Plain radiographs are important for establishing if there might be an associated fracture. Many times a fracture might be a small fragment, such as this one, or a much larger chunk which is significantly compromising the congruity of the joint surface of the base of the proximal phalanx. There is some confusion and controversy in the literature about the situation where clinically there is a complete rupture of the ulnar collateral ligament, so one is wondering whether it might be a steno lesion. But a plain X-ray shows a fracture fragment, like in this X-ray where the fracture fragment is undisplaced. Intuitively, one might surmise that the ulnar collateral ligament, shown here in red, is attached to the avulsion fragment, which is undisplaced. As such, it is thought that the UCL is located optimally at the base of the proximal phalanx to ensure healing. An operative intervention is unnecessary. As there is no gap between the avulsion fragment and the base of the proximal phalanx, there can be no steno lesion. However, there have been numerous reports in the literature which confirm that it is possible for there to be a fracture fragment of the base of the proximal phalanx and also a rupture of the ulnar collateral ligament from the fragment. So therefore, the position of the fracture fragment cannot necessarily be used as a reliable indicator of the position of the UCL. Therefore, this of course means that the presence of an undisplaced fracture of the base of the proximal phalanx seen on X-ray does not preclude a steno lesion being present. So, to emphasise, if there is clinical evidence of complete rupture of the UCL, one must assume that there might be an associated steno lesion, notwithstanding an undisplaced fracture of the base of the proximal phalanx. If there is a steno lesion, this needs to be addressed operatively to allow the ulnar collateral ligament to be repositioned deep to the aponeurosis so it can heal appropriately. Some clinicians have suggested that one can diagnose a steno lesion clinically by palpating the area of injury and feeling for a lump. This can be quite difficult, especially in the presence of swelling and tenderness. Similarly, in our experience, ultrasound and MRI scans are not necessarily reliable in being able to diagnose the presence or absence of a steno lesion. We assert that a steno lesion can only predictably be diagnosed by direct vision intraoperatively. The treatment plan is as follows. If there is an endpoint, that is to say that the UCL has been incompletely ruptured, the MCPJ is immobilised for 6 to 8 weeks to allow complete healing of the UCL, followed by graduated mobilisation. If there is no endpoint, that is to say there is demonstrable instability on radial stressing of the MCPJ of the thumb, then one has to assume that a steno lesion might be present. And as direct visualization is the only predictable method to ascertain the presence or absence of a steno lesion, we advise operative exploration and repair of the UCL as necessary. It is important to understand that the undesirable implications of missing a steno lesion, a painful, unstable thumb, far outweighs the minor operative risks and the short scar associated with operative exploration, whereby the UCL is found to be ruptured, but a steno lesion has not resulted. At operation, proper ulnar collateral ligament is reattached to the bone, the accessory UCL is attached to the volar plate, and the dorsal capsule, as it is often injured, is repaired as well. I hope you found this video useful in the diagnosis and treatment of ulnar collateral ligament injuries.